So, hi to everyone, and again, thank you very much for the invitation to speak at the Asian Stroke Summer School. My name is Pasquale Mordasini. I am the head of the Neurointerventional Unit at the University Hospital in Bern, and my talk today will be about complex stroke treatment and tandem lesions. I'm going to share my screen now. So this is going to be my topic over the next couple of minutes. So if we talk about tandem occlusions, we have to be aware that it's a quite frequent setting in acute stroke treatment. So 10 to 20% of major strokes are indeed tandem occlusions, meaning an extracranial ICA with an intracranial ICA or MCA occlusion. We know that those tandem occlusions have a poor outcome in the natural course of the disease with a very high morbidity and mortality. And they also have a poor response to intravenous thrombolysis alone with low recanalization rates and a high rate of unfavorable outcome. We also have to keep in mind that there are different etiologies of the cervical ICA lesions. Most of them are antisclerotic, but also you can have dissections, you can have large thrombemboli, which are just occluding the ICA, or you can have a web as a more rare, but also existing cause of the cervical ICA lesion. And the endovascular treatment with stent retrievers with or without concomitant stenting of the underlying obstructive ICA lesion is an emerging treatment option. So the endovascular treatment is a little bit more challenging, and the optimal treatment strategies are still unclear. So should we use an antegrade or a retrograde approach? Should we stent, or can we just do a PTA or leave everything alone? If we stent, what are our antiplatelet strategies? And going with that, what is the risk of symptomatic intracranial hemorrhage? And are there other risks for complications like distal emboli? So if we just look at one of the latest meta-analysis looking at the outcomes data of the treatment of tandem occlusions in acute stroke, we see that the basic outcome data, so clinical outcome, recanalization success, and also complications, including symptomatic intracranial hemorrhages, are in the range of what we know from just single occlusion thrombectomy, like for M1 or carotid T occlusion. So the treatment results overall seem to be quite similar to isolated large vessel occlusions. So if we stent in those cases, what are the potential advantages of an acute stent placement? For example, the treatment of the causative embolic lesion and to lower the risk of stroke recurrence, to improve the cerebral perfusion with the potential attenuation of infarct progression, and to contribute by improving the perfusion to the spontaneous intracranial clot lysis or to the effect of the IV thrombolytics. But what might be potential disadvantages or the advantages of not putting a stent, or the disadvantages of the stent? So we might have a low risk of intracranial hemorrhage because we avoid hyperperfusion and we avoid acute antiplatelet agents. We may lower the risk of iatrogenic artery-to-artery embolization during stent deployment. There is no risk of stent thrombosis or any problems with the stent if we don't put one. It avoids delays in intracranial recanalization. If we stent first and we may have problems, we may delay the intracranial thrombectomy. We may lower the risk of procedural bradycardia and hypotension from carotid baroreceptor activation with stent placement. However, in our opinion, there are some rationales to stent. For sure, if we have to gain intracranial access, and if this is not possible without stenting or PTA in the ICA first, we don't have our access, and therefore we cannot treat the intracranial occlusion. So this is for sure a good reason to put a stent in the acute phase. The second reason is that the stroke recurrence due to intracranial re-embolization or to hemodynamic impairment in case of a symptomatic ICA occlusion or stenosis may be different from what we know from the literature from symptomatic carotid stenosis that are being treated semi-electively with stenting or endarterectomy. There is some data showing that they have a substantial risk of early embolic recurrence when intraluminal thrombus is associated with ICA occlusion or stenosis. There are some series and they show a risk of recurrence of almost 30%. And if you look at those images here on the right-hand corner, these are lesions we see in the acute phase, and these are definitely different type of carotid stenosis and plaques than we see when we have a symptomatic carotid stenosis and treat them a couple of days later. So here I think it makes sense to do a one-stop treatment. It has also shown that in, again, meta-analysis and reviews that stenting seems to be even favorable, or at least there is no obvious sign that stenting is overall decreasing the rate of good outcome. So here in this meta-analysis with more than 1,600 patients, acute stenting was associated with a favorable outcome, clinical outcome, and there were no statistically significant differences for 3 months mortality or symptomatic intracranial hemorrhages. So among patients with tandem lesions undergoing endovascular treatment, acute carotid stenting is associated with a greater likelihood of favorable outcome at 90 days compared with no stenting in observational series. Again, we have also to, of course, to discern between the different etiologies. So we have the atraumatic lesions, we have dissections, and they usually in all those series, they are just put together. But these are different disease entities, it's a different patient population, and of course, there is a different pathophysiologic origin behind those pathologies. So for atherosclerotic lesions, you have a vulnerable plaque, they're older patients, they might be more prone to good leptomeningeal collaterals and having a larger mismatch. They might have a higher stroke recurrence rate because these are symptomatic carotid stenosis. The navigation through the high-grade stenosis and stenting is here a major technical problem. On the other hand, for ICA dissections, we have the intramural hematoma. They tend to be younger patients. They probably are less prone to have good leptomeningeal collaterals and maybe less mismatch. The stroke recurrence rate, on the other hand, is very low compared to atherosclerotic lesions. And here the technical difficulties consist of navigating into the true lumen and not to mobilize in situ thrombus during stenting. So when we approach those tandem lesions, I think there are some technical aspects you should be aware of, or you should think of. So we usually take a large bore balloon guiding catheter, and 9 French usually, and put it into the ICA or in the stump of the occlusion. And we are starting to try to pass the occlusion under flow arrest. This is very important that you work on the flow arrest. You either achieve that, as I said, with balloon occlusion catheters, or if you take a large bore guiding catheter and just wedge the guiding catheter in the lesion. And then you can pass in a safe way. Here it is, but this is the orthopedic procedure or part of the procedure. You really have to push your catheter through this chronic occlusion. And this is sometimes difficult to achieve. But in around 10 to 15%, but in only around 10 to 15% of cases, in our experience, you really need to PTA or stent the ICA first in order just to be able to pass it. And be aware, this is an unclear and unpredictable situation. You don't know what's behind the stenosis. You even, most of the times, don't really know, is it really atherosclerotic, or is it a dissection, or is it a thrombus? And you don't know what's behind it, whether there is a large thrombus mass, whether it is an ulcerated tract, or whether it's just a clean ICA without any pathology. So therefore, the flow arrest on the way up to pass the stenosis is of utmost importance, because here you have a risk of dislodging whatever might lie behind the stenosis or occlusion. And then we usually do the intracranial thrombectomy. I come back to that later. And then on the way back, under protection with a filter wire, I show you this. Then we look what's going on in the ICA. And then you can see you have different types of lesions, large calcified plaques, large dissections, or large apposition thrombi, and then you can decide based on those imaging what are your next steps. Do you really need to stent? Do you just want to PTA? Do you want to put in a stent, or you just leave it like that? And as I already mentioned, there are two technical approaches to approach tandem lesions. One is the so-called antegrade approach, which means we start with the proximal lesion first and then do the distal intracranial thrombectomy in the second step. So there are advantages are that you might have distal protection against emboli by the intracranial occlusion, but this is not really true. If you just have an M1 occlusion, you can still have emboli into the ACA or in the posterior cerebral artery. And even if you have a T occlusion, you might have a fetal PCA, which is not protected, so to speak, and you might have distal emboli into this vessel. You restore the flow in the ICA first by choosing this approach, and this might help to circulate lytics. However, in our opinion, there are certain disadvantages, and the most important disadvantages, I think, is that in most of these patients, the symptomatic lesion is the intracranial occlusion. So let's treat the intracranial occlusion first and not lose time by addressing the more proximal occlusion, because there might be a time delay until you really have nicely stented or treated the ICA. And during this time, you delay the intracranial occlusion. And the second approach is our personal favorite approach, which we try to apply whenever possible, which is the retrograde approach. So we pass the occlusion. We're not addressing the ICA lesion first, but we first go distally. We do the intracranial thrombectomy after passing the occlusion, and then work back distally, proximally, to address the ICA lesions. So I think the advantages here are that, as I said, the target lesions, so the symptomatic intracranial lesion is treated first to restore perfusion. Because you have a balloon guide or a wedge catheter in the ICA, you're working on the flow arrest, so you minimize the risk of distal embolization. And then you can decide on the way back what you're going to do with the ICA. You can make the image, you can then finally see what's going on there and base your decision on how to go on these images. However, in order to do that, and that's the disadvantage of this technique, you have to restore the flow. And in this moment, I think this is a crucial moment. You're not sure what's going to happen if you have flow on this ICA. So maybe you will have this emboli at this moment. So what we do is, when we intracranially recanalize, as you can see here in these pictures, we go back to the upper cervical level. And if this is clean and not occluded, we put in a filter wire. Then we start to aspirate in the ICA and try to clean as much as possible. And only then we deflate the balloon or retrieve the catheter in order to restore flow and in order to do the control angiogram. So the control angiogram is done under protection, under distal protection. And then we see what we want. Then we see the lesion, and then we can decide what to do. And of course, the other disadvantage of the retrograde approach, of course, is if you're not able to pass the lesion, of course, then you have to choose an antegrade approach first. So this is a case just to show you those principles and why we think this is important. It's a carotid occlusion. We don't really know what's going on there. Is it atherosclerotic? Is there a large thrombosperm behind that? And it was an M1 occlusion intracranially. So we just passed it with a large bore catheter. We are now wedged in the ICA and with an intermediate catheter, and we just performed the intracranial thrombectomy with complete recanalization. And then on the way back, we put in the filter. Then we retrieve the guiding catheter and the intermediate catheters and do the angio run. And we have this picture here. I'm sorry, it's a little bit small, but it looks like an ulcerated plaque. So that's why I decided to put in a stent, which went very nicely. However, if you have a very good look, and I'm very sorry because the images are small, you can see that there is something in the filter. Here you can see it more nicely. There is something in the filter after the stenting procedure, and this is a distal embolus. This was an embolus that we only caused because we had the filter in place. And you can see there was no distal embolization of the intracranial vasculature. So in order to avoid that, I think it's very useful that you, before you restore flow in the ICA, have a filter in place to protect distally. The same technical rules we apply also for the posterior circulation. This is a case with a vertebral artery orifice stenosis, probably a thrombus there, and the basilar artery occlusion. So we again passed the occlusion proximally. We made recanalization intracranially, which went very swiftly and quickly. On the way back, we deployed the filter, probably you can see it here in this vertebral artery, and then we decided to stent the stenosis at the orifice. However, there was something distal to the stent. What is it? Is it a dissection? Is it a thrombus? I went there and tried to aspirate it, and it was gone. So what was it? It was clear what it was. It was a huge thrombus, a position thrombus, which we called in the filter. Again, this was the protection from the intracranial circulation, no distal embolus, and we could had everything under control. So I think this is very important. This is the third case, just to show you what might happen if you don't follow your own rules. This was a case of a patient with an ICA occlusion, and you can see that the tip of the thrombus is just lodging into the carotid T, but there is no MCA occlusion or no ACA occlusion. Again, you don't really know what's going on the cervical level. Here we passed just with the intermediate catheter on the flow arrest with the balloon guiding catheter, and we aspirated. And it was very quickly, and we aspirated a lot of thrombus, and we already recanalized intracranially. So we were very happy. So what you do first, of course, now you do the control round, you deflate the balloon, you do the control round, and now what happened? Now we have a T occlusion, we have a thrombus in the carotid T and a thrombus in this fetal PCA. Why? Because there was still some thrombus here lodging in the proximal ICA. We didn't know that, we didn't put in the filter, we were not careful enough. And then, of course, if we restore the flow and if we inject, we might have risk of dislodging those thrombi. So here we didn't follow our own rules, and indeed we had a distal embolization. We needed to go back. We had to do thrombectomy in the carotid T and in the PCA. Fortunately, we were able to recanalize and had a good recanalization result. So I already mentioned the different etiologies. So let's focus a moment on ICA dissections. So we know that cervical ICA dissections have a favorable prognosis with medical treatment. There's a high rate of functional independence and a low rate of stroke recurrence. So it's usually less than 3% with pharmacological or medical treatment. However, there might be a subgroup of patients with severe or progressive neurological symptoms with dissections due to hemodynamic impairment, or to a high thrombus burden of wall adherent thrombus. So there might be a risk of extra intracranial vessel occlusion, or a combination of both. And I think those are the only patients that are possible targets for endovascular treatment of the dissection itself in the acute setting. Yes, we can do that. It has a high technical success rate, but it's sometimes very difficult. However, if we go to the literature, there is a certain risk of thromboembolism or thrombus formations in those patients. So we have to be careful. If we put in a stent, we have to have a good reason, because most of those patients, they get away without a stent. And we looked at our data together with our colleagues from Montpellier at the time, looking at tandem occlusions with dissections. And this is a case, and we had very good results. And what we do is we assess the hemodynamics and the circle of Willis. Here in this case, for example, with an M1 occlusion and the left ICA dissection, we did the intracranial thrombectomy, as you can see. And then we had this long-standing ICA dissection. We saw that on the contralateral injection, the collateralization is very sufficient. So we decided to leave the lesion alone, put the patient on the conservative pharmacological treatment. And again, this is a control follow-up after 3 months with complete reconstitution of the ICA under just medical treatment. So be aware of that. Because when we put in stents, there is always to weigh the risk and benefit ratio between hemorrhagic complication and, of course, thrombotic and thromboembolic complications due to recurrent stroke or stent occlusions. So let's have a look at antiplatelet therapy and risk of hemorrhage. The literature is very homogeneous. There are a lot of multi and single center series with a lot of different antiplatelet regimens, and the reported rate of symptomatic intracranial hemorrhage is around 10%, with some series showing higher rates of intracranial hemorrhage up to 30%. There has been the Titan registry looking at tandem occlusions and endovascular therapy of tandem occlusions. They looked on the impact of antiplatelet therapy. So they looked at the endovascularly treated patients with tandem occlusions and compared those who received antiplatelet medications and those not. Those with antiplatelet medication usually also got a stent, and they found that there was a non-significant trend to a high rate of favorable outcome with antiplatelet therapies, around 60% to 46%. There was a significantly lower rate of mortality, and there was a significantly higher successful reperfusion rate, 83 to 71% in the group who received antiplatelets. So the administration of antiplatelet therapy to the endovascular treatment for anterior circulation tandem occlusions in this broad series was safe and was associated with a lower mortality at 90 days. So what with intravenous thrombolysis, if the patient has additional to the antiplatelet therapy intravenous thrombolysis on board, again, there is data from these Titan registries, and they found that in those patients, prior intravenous thrombolysis and emergency stenting with additional antiplatelet administration was associated with higher perfusion rates, and the pre-treatment administration of IV-TPA was not associated with a high risk of hemorrhagic complications. So it seems overall to be pretty safe. However, if you have bleeding, what's the frequency and what's the clinical consequence? Again, from the Titan registry, we have some data. Around 25% show hemorrhagic infarction and around 14% parenchymal hematoma. And the predictors in those series was intracranial ICA occlusion, diabetes, and extracranial ICA occlusion, and for patients with parenchymal hemorrhage, a higher NHSS score representation and a lower aspect scores were predictors. However, not found as predictors was prior use of IV-TPA, ICA stenting, and such antiplatelet therapy as such. And here we can see the clinical impact of hemorrhagic infarction and parenchymal hemorrhage if it occurs. Again, this is data from Titan. So the hemorrhagic infarctions, they didn't seem to have a significant detrimental effect on the clinical outcome. Parenchymal hemorrhage was associated with a decreased rate of favorable outcome. However, if you adjust it for the predictors of hemorrhagic transformation, the detrimental effect was only seen in the shift analysis for clinical outcome. However, there was an increased mortality rate in these patients. So nevertheless, we apply a drug, we apply a procedure, and we change something. So on the other hand, what's the risk or what's the complication for thromboembolic complications? So interestingly, most studies about tandem occlusions, they're focusing on reporting reperfusion rates, outcome rates, and rates of symptomatic hemorrhages, and there is only very few data indeed about stent patency rates and stent occlusion rates available. What is available reports occlusion rates or delayed stent thrombosis rates around 5 to 30%. Positive factors are, of course, these patients are usually not pre-treated, and there is a variability of peri-procedural antiplatelet or anticoagulation protocols, and also differences of implanted stents. There is one series that tried to look a little bit at predictors and the clinical impact of stent thrombosis after thrombectomy and tandem occlusions. And here in those series, they had quite a high stent occlusion rate of almost 30%. Just with aspirin, and a lower rate with aspirin and clopidogrel. This is not what our experience. I think we have around a stent occlusion rate just with aspirin of around 5%. But what is important, if the stent occlude, almost all of them occlude within the first 24 hours. And in this series, around 20% of patients with stent occlusions, they had some aggravation of neurological deficit, maybe due to hemodynamic impairment in the MCA, and stent occlusion was a predictor of bad outcome at follow-up. So there is a non-negligible rate of delayed stent thrombosis, which may impact the clinical outcome, and we need more systematic follow-up of stent patency, and we need to incorporate stent patency and stent data in future studies. And if they looked at predictors of stent occlusions, we have some clinical predictors like diabetes, but also whether there was whether there was thrombus in the stent during the procedure. And of course, we would wait and see that everything is okay with the stent before we take the patient up from the table. So there seems to be a link between occurrence of interprocedural thrombosis and patency, and we should have a look at that. Of course, there is also an impact of the stents we use. We know there are differences in stent designs. Most series, they use laser cut stents. The situation is sometimes a little bit different from elective stenting cases because sometimes it's difficult to have a good sizing. Sometimes it's subnominal or nominal diameter dilatation for good wall adaptation, or even not. And maybe we have to use constructs with overlapping stents. And in elective cases, the introduction of those stents, mesh stent, was clearly an advantage, at least in our hand, because they have an improved carotid plaque coverage. But are they more thrombogenic to use them in the acute phase? And for example, there is some data now available on the Casper stent, for example, where there seems to be in a trend to have more thromboembolic complications in the acute phase. There are series to reported over 50%. So to sum up, what are factors that influence our decision to stent or not to stent in the acute phase? So what is the lesion etiology? If it's rather atherosclerotic, we rather opt for stenting. If it's dissection, we try to avoid stenting as much as possible. We have also to take clinical parameters into consideration. The infarct course, is it small or large? Larger infarct course have a higher risk of hemorrhagic transformation. Also, whether we have achieved a good intracranial recanalization. If we have failed to recanalize intracranially, probably it's not worth taking any risk of recanalizing extracranially. What is the collateral status? Do we need to recanalize the ICA for hemodynamic reasons? Is there any dynamic ICA reocclusion already during the procedure, during the intervention? If so, that points more in the direction to be more active and go on for stenting. If everything is clean and stable, then this is rather an argument to stay conservative. Has the IV thrombolysis used, and what else anticoagulation is on board? Is there an additional systemic bleeding risk, and what is there any indication for long-term anticoagulation anyway? So I've presented you many ways, many thoughts on how things are done or how we do it. And of course, you need more data, and there's some randomized control trials now on the way or being performed. One is the Titan trial, which is performed in France, and the other one is the EasyTalk trial, which is performed in Northern America, which addresses tandem occlusions and stenting in tandem occlusions in the acute phase of stroke. And hopefully those studies will give us some more information in order to be able to formulate guidelines on how to treat these lesions. So to conclude, mechanical thrombectomy and tandem occlusions seems to have the same high treatment effect as isolated large vessel occlusions. Overall stenting of the cervical ICA in the acute setting of stroke seems not to reduce the positive treatment effect. A non-aggressive antiplatelet regimen with just aspirin seems to be a reasonable trade-off between the risk of symptomatic stent occlusion and hemorrhage, at least in our experience. And the decision to stent should be based on individual patient selection, for example, the lesion etiology, morphology, residual adherent thrombus, hemodynamic impairment, the NHSS, clinical presentation, infarct, core and comorbidities such as diabetes. And of course, the stents and techniques that are used are important, and we should use material that is as non-thrombogenic as possible. And despite the recent randomized controlled trials demonstrating the effectiveness of mechanical thrombectomy, there is still a research gap about the management of tandem occlusions, and those randomized trials hopefully will help us to formulate guidelines for the endovascular treatment of tandem occlusions. So thank you very much. It was a pleasure joining you virtually, and I wish you all the best and a nice and interesting further Asian stroke summer school. Thank you very much.